uses that you come across when you're working in the pediatric ICU. And so for foreign body aspiration, it says it may present as a sudden onset of cough or wheezing in an infant. So they can be completely normal, no cold, no nothing, and all of a sudden they're coughing a lot. You can possibly hear wheezing. That's a sign that they may have put something in their mouth, because they go through that oral stage where they learn their environment by putting things in their mouth. And they put all kinds of things in their mouth. And they come across something on the floor, and of course they want to put it in their mouth. And then once it's in their mouth, and they can aspirate or swallow it, it ends up in their airway, in their upper airway, and they'll start coughing a lot. It says the diagnosis for aspirating a foreign body is via bronchoscopy or chest x-ray. So the parent will bring the child or infant to the ER, and that's the first thing they'll do is take an x-ray. If atelectasis occurs, it occurs because of complete obstruction of the bronchus. So if it's something that can be inhaled, and it can get down into the right mediastem bronchus or the left mediastem bronchus, and it includes the conducting airways after that point, then within a little bit, all the alveoli are going to collapse, because there's no air going into the alveoli, and they'll end up collapsing. So you'll see atelectasis. Doing a Heimlich on an infant and a child less than 3 years of age would damage abdominal organs. So instead, you do back blows and chest thrusts. Alright, so on your exam, you'll have a scenario, and it's going to read just like that, where an infant who is well, no history of cold or any problems with their lungs, presents with sudden wheezing and coughing. You suspect that they aspirated an object into their airway. What would you do? And then, of course, A is going to be you open the mouth and you stick your finger in and you try to locate the object and pull it out. Is that a good idea?
No, you can shove it further.
Yeah. So the fear is you're going to push it further into their little airway and completely obstruct their airway. So they'll have no air movement whatsoever. So if you see the object, is it okay to pull it out if you can see it?
Yes.
Yes.
Okay, the next slide shows an x-ray of jacks. I don't even know if you guys know what jacks are. So how do you think you can get that out of their airway?
Bronch? Rigid bronch, right?
Rigid, I don't know if it would fit through rigid, but how about using forceps to grab it and then pull the whole thing out? When you're doing a bronchoscopy, there's different objects you can put through the bronchoscopy tube. And one of them is forceps. And you feed it through, and then there's a way to control the biting. Yeah, it's how they take a sample of a tumor or part of the mucosa that looks like it's abnormal. You feed the forceps through the bronchoscope, get it wedged on the mucosal wall, and then squeeze the forceps, and it pinches the tissue and pulls it. Yeah, there's no pain sensation in that conducting airways, but there is a lot of bleeding. So usually they inject epinephrine because of the alpha-1 constricting properties, and that kind of controls the bleeding. There's also a snare, which is something that opens up like a basket. Like you feed it down, and then when you pull back, the snare opens up, and then that's another way of getting objects out of the airway. So that's all I had for foreign body aspiration. And then we move on to head trauma. Brain injury occurs once every 15 seconds in the United States. And it's the primary cause of traumatic death in the United States.
So for pediatric illnesses or just?
In general.
In general.
Head trauma in children, less than 1 year of age, most commonly caused by falls, and then it explains why. So the infant has a large and heavy head relative to their body. And they are not yet fully coordinated. They're more vulnerable to falls with head injury. And it doesn't say it here, but they love to climb. Next is automobile accidents. So you might think, well, wait a minute, they're in a car seat. How can they injure their head? But sometimes the car seat is put in the back seat and you go about your business, and then it's time to go to the store, and then you put the baby in the car seat, but you forgot that you're supposed to secure the car seat to the seat. So even though they're in a car seat, the car seat may not have been secured. So it's still, and then they don't even put kids in car seats. The shaken baby syndrome. So when the baby is crying, the caregiver thinks, well, if I shake them and yell at them, they're going to stop crying. But when you shake a baby, it causes their brain to hit the front of their skull and then hit the back of their skull. So it causes brain damage. And Kids Corner, like go to Kids Corner, they're full of kids that are shaken baby syndrome. So it's nice to know that 89 to 95% of infants aged 4 months to 5 years who had falls of 8 inches to 10 feet had no significant long-term problems. That's good to hear because my son I was driving, my car broke down, so I'm carrying my son who was 6 months old in the car seat, walking back to the house, and he decided to lurch out of my hand, so he went back and landed on his head.
Oh my gosh.
Took him to the ER. He did have a fractured skull, and the doctor said, don't worry about it. You know, if he gets really sleepy, come back right away. But otherwise, he'll be fine. So infants have a malleable skull, meaning that it's soft because the bones have not fused. And then they have fontanelles, which are places where the bones haven't grown yet, so that you can touch the soft part of their brain, or soft part of the skull. A bulging fontanelle is not a good sign, but it's normally soft. Anyway, because the brain has a little bit of a place to go, I guess, it minimizes the amount of trauma to the brain. The issue with the brain is if there's any brain swelling, especially more so with adults than babies that have this malleable skull. With adults, when there's brain swelling, there's no place for the brain to expand. So a lot of pressure builds up and it damages brain tissue.
Which is why they do craniectomy.
Which is why they'll do a craniectomy. They'll bore a hole through the skull to relieve excess pressure by draining some cerebrospinal fluid.
That's the one where they have it and it's like the levers like balance to where their head is, right?
Yes.
Okay.
Yeah. And you should see a reading for ICP at the moment.
Yeah.
Alright, that's all I have for head trauma, and then we move on to
Child abuse.
child abuse. Suspect child abuse if the child draws away or cringes when the parent approaches. The infant or child, if they have multiple bruises of varying ages, suspect child abuse. If they suddenly become nonverbal or their behavior changes when the parent approaches, suspect child abuse. So child abuse can be physical and it can be emotional too. And so as we as respiratory therapists, how do we fit into the role of child abuse? Where we were talking about this with home care, where you contact the home care company or the social worker in charge of that child or infant. Inside the hospital, nursing is in contact with social workers. with head trauma, you assess the state of consciousness by using the Glasgow Coma Scale. The scale is more accurate with adolescents and adults, and I have it coming, but it says less than 4. So if you have a Glasgow Coma Scale less than 4, so what does that give you? Like 3?
No one.
Because there's, we need to look at it. Let me scroll ahead. The next slide shows the Glasgow Coma Scale. So if your eyes don't open, if you have no verbal response and no motor response, you get a 3. That's as low as you can go. There's no zeros. So this scoring for level of consciousness, have you guys learned this already? With verbal response, if a baby is oriented, they will cool and babble. If they're confused, we notice if they're irritable or crying, we consider that confused. If they're old enough to speak, no. If they cry to pain, then that's a 3. Non-specific sounds like moaning is a 2, and then no verbal response. So you can do the Glasgow Coma Scale on infants and children. So there is a test question on when would you suspect permanent neurologic damage according to the Glasgow Coma Scale, and your answer is going to be if it's less than 4, you have an 80% chance of dying or having permanent brain damage. And better than 6. So how would you get better than 6? If the next one up. 2, 4, 6. And you have a good chance of survival and being mobile. So better than 6, very low risk of permanent neurologic sequelae. So one of the things I never understood working in the ER is the patient would come in as a trauma and they're confused, but they're still talking, they're breathing fine, and then they need to be intubated. I could never understand, why are we intubating this person? But the reason is to protect their airway. I guess if they go unconscious at a certain point, at least we have an airway established, and we can be ventilating them in case anything goes on. So it's almost like a prophylactic intubation. And then in my notes, I also have, if the Glasgow Coma Scale is less than 8, intubate to protect the airway. It says avoid overextension of the head, which could make a possible spinal fracture worse. The best way to visualize the cords is to hyperextend the head to get the tube in. But by hyperextending the head, you can cause more damage to the spinal cord. We talked about hyperventilation. So the thought is if you hyperventilate, you get an awful lot of pH or low CO2, the response of the cerebral vessels is to constrict. If you constrict the cerebral vessels, you have less blood flow into the brain, and then you'll have less pressure in the brain because of it. That was not a good idea because it was not allowing good enough blood flow to the brain, and they found out that people had worse neurologic outcomes if you do that. But here it's saying it's okay for the first 2 hours, or don't do it at all. So if you want to maintain cerebral perfusion pressure, you have to know what the blood pressure is, and you have to know what the intracranial pressure is. If the difference between the two is 50, then you've got good perfusion to the brain. So it gives you normals at the bottom. So a normal intracranial pressure is 20 millimeters mercury. Normal mean arterial pressure, 90 millimeters mercury. And when you subtract those two numbers, you notice that they're better than 50. So that tells you you've got good blood flow to the brain. So a head trauma that causes unconsciousness, but the person wakes up in less than 5 minutes, that's considered mild injury. Isn't that crazy? You can knock somebody unconscious and it's considered mild head trauma. If there is paralysis, it quickly resolves. And then severe injury is the person stays unconscious more than 5 minutes. They may have seizures. When they wake up, they're very disoriented, and then they have a persistent headache. So that's considered severe injury. Now the problem with head trauma is the edema doesn't occur immediately upon the injury, but it takes about 24 hours for the edema to be at its worst. So as the edema occurs, you're going to see less orientation, more disorientation, and more seizures. So for the severe injury, where you're disoriented, persistent headache, seizures, that happens going unconscious again if the edema gets worse. So as the edema gets worse, everything under the severe injury shows up. I guess that's a better way to say it. It talks about the brain bruise on the opposite side as the brain hits the skull upon impact. And there's a picture next that shows that. I have some notes for you to write down also. The impact causes blood vessels to rupture. So write that down. Impact causes blood vessels to rupture. The blood or hematoma puts pressure on the brain tissue. So the blood or hematoma puts pressure on the brain tissue. So the blood or hematoma puts pressure on brain tissue. Okay, and then brain bruise may be on opposite side as the brain hits the skull upon impact. So if you're walking and looking at your phone, you don't realize it, and you walk right into a pole, and you're walking pretty fast. You're hitting the front of your head, but as you hit, then the brain will move back. So forward, and then they call it contra coup. So when it goes to the back of your skull, it's usually where you get most of the bleeding. So it's opposite to the side that had the impact. Does this talk about coup and contra coup? No. So write down the word C-O-U-P, coup, and it means impact. So coup means impact. And then write down contra coup, C-O-U-P. And that's the opposite from the impact. So contra coup is opposite from the impact. So the picture that you're looking at on your slide, you can see a dark area, so I think it's mimicking a hematoma. So the brain goes forward, hits the front, but then it snaps back and hits the back. So you get bleeding in the opposite side also. On the next slide, it talks about 1, 2, 3, 4, 5 levels of head trauma. Concussion, contusion, skull fracture, depressed bone, and then basilar skull fracture. So with a concussion, there is loss of awareness for a few minutes. Contusion is an actual bruise to the brain. Skull fracture, it says linear if the bone doesn't move. So you can see the split, but it's not completely around, so you don't have any movement of the bone itself. And then depressed bone, there's enough of brokenness and then a basilar skull fracture, having a fracture at the base of the skull will cause leakage of fluid into the eyes and ears. Okay, and the patient will posture a certain way when there's brain damage. It says the position that a person's body assumes after head injury can be diagnostic of the level of brain function. I don't have it in my notes. Oh yeah, I do. Brainstem, cerebellar is the brainstem. Cortical is midbrain. Is midbrain. Alright, so the first one it talks about is decerebrate posturing. What do I have here? The arms twist inward and the toes are flexed. It doesn't say that on there, so I'll let you write it down. Yeah. So the second bullet where it says decerebrate posturing, that's what we're talking about right now. The arms twist inward and the toes are flexed. So the arms twist inward and the toes are flexed. Does it say that on there? Decerebrate brainstem has been affected. Decerebrate. So either there's damage of the brainstem or compression of the brainstem. Should I repeat that so you can read it?
Yeah.
So in the second bullet for decerebrate posturing, it says brainstem has been affected. I also have damage or compression of the brainstem. It's just clarifying that bullet. Damage or compression of the brainstem. And then for deformicate posturing in the comatose patient, they have the arms are bent at the elbows. That's not on there, so if you want to write it down. Arms are bent at the elbows and at the wrist. So arms are bent at the elbows and at the wrists. This is the, decorticate is midbrain affected? Did we already say that?
No, yeah, that's right.
Decorticate is midbrain has been affected. Where is the midbrain? It's above the pons. So I guess a little higher up from the cerebellum.
Does it damage your compression like the other one?
No,
Just affecting?
yeah. So midbrain is affected, arms are bent to the elbows and at the wrists, and it can happen in response to pain. So I guess doing a sternal rub to see how if the person will respond to pain, and instead they bring their arms up and their hands curled in, that indicates that their midbrain has been affected. Okay, so look at this picture and tell me which one is the cerebrit and which one is the cortex. Okay, how about this? Which picture shows that the midbrain has been affected?
A.
Yes, very good. And then, I have Babinski reflex written down, and this is when the toes extend, when the bottom of the foot is stimulated with like a pen or something. Babinski reflex. So, you want me to spell it for you?
Yep.
B-I-N.
B-A-B. Babinski.
Oh, with a B, not with a.
Yeah, B-A-B. Like baby, B-A-B-I. N-S-K-I, Babinski. Babinski reflex,
You said that's what again?
the toes extend. When the bottom of the foot is, well, let me explain it first and then figure out the words. So if you have like the back of a pen, which sounds disgusting, especially when you see some of the feet in these patients. On the bottom of the foot, if you take your pen and go up the foot, and you see the toes spread out and extend, that shows that they have Babinski reflex, and what somewhere in the brain is damaged, and I don't have that part written down. I just have Babinski reflex is when the toes extend, when the bottom of the foot is stimulated.
What does that indicate again?
Brain injury. Doesn't everybody extend their toes?
Well, maybe not extended, I guess.
It's like the opposite reaction of what you would normally do for
Oh,
that.
yeah, you would.
Yeah, you would crow.
You would, yeah.
So as opposed to like bursting out laughing, somebody tickles your foot.
Yeah,
Or-
but if
or
they tickle
kicking.
your foot usually goes like this because it tickles.
I remember working at Mount Carmel Hospital in Detroit when I first graduated from respiratory school. Working, and of course you get like evening shift or the shifts nobody wants. So a patient comes out of surgery and, on a ventilator, and I get a call from Dr. Holt. He says, Yvonne, I want you to go into the patient's room, take your pen, and, go up the patient's foot and tell me what happens to the toes. I'll wait on the phone until you come back. So I did it with my pen. I go in there and I go in, the toes go up, and I go back to the phone. Now, I had no idea why he was asking me this or what it meant. So I probably said, oh yeah, the toes went all the way out. He goes, okay, that's all I needed to hear, thank you, goodbye. Well, what happened is during surgery, I guess the endotube came out and they didn't catch it, and there was brain damage from the patient being unventilated during the surgical procedure. And that's what he was looking for. He wanted to, I guess he didn't want to physically go there himself, make a big deal out of it. So he sends me in there, and that's why I remember, oh, the toes going out. Now I know that that was not a good thing. you know, me over the phone, yeah, the toes, they went all the way out. Yeah, I learned so much after I started teaching.
Everything came together like, oh.
Yes. Why is, there's a lot of sickle cell kids in pediatric ICU, that's why we have this slide here. I feel like we talked about this recently, or maybe it was with first year students.
Yeah, people over sickle cell with them.
Yeah. So certain conditions cause red blood cells to change shape, and when they do, they change shape and they occlude blood vessels, or the capillaries at least. So low oxygen can be a trigger. Low pH can trigger it. Rapid temperature changes. Dehydration can also cause the red cells to sink. Pulmonary complications are the primary cause of illness and death in patients with sickle cell disease. And they call it acute chest syndrome when they're in pediatric ICU. The patient comes in with a lot of pruritic pain or chest wall pain or short of breath. And this is from their pulmonary vessels becoming injured. And then, of course, the tissue that's fed by those vessels. So they get pulmonary infarction, and pneumonia loves to set in anytime you have inflammation, so they end up with a pneumonia. I know this sounds like it's not important, but I think it's a test question, so I'm going to have you write it down anyway. The chest x-ray shows, and let me tell you what to look for. You'll have pulmonary infiltrates, atelectasis, and pleural effusion. There's a difference. Did you get all that? Should I repeat it?
Got it.
There's a difference in how children present versus how adults present. Adults present with no fever but severe pain. So adults present with no fever, but they have severe pain. Children present with fever and cough and have no pain. They present with fever and cough but have no pain.
I thought they did have chest wall.
Yeah, it says they present with pruritic or chest wall pain and dyspnea. And here in children, it says they do not present with pain. It is kind of a
But then you said the adults don't either, so who does?
No, they do.
Oh, they do. With no, oh, no
Adults have
fever,
no
but,
fever, but severe pain.
and then the children don't. I think I had it, well, he was like maybe 12, he had chest pain.
He did.
But maybe because he was older.
I wonder.
So, the best question is that itself, or?
Yeah. Well, I'll look it up for, when do you guys take this test?
Next week.
Is that the deadline, or is it only open next Monday?
Is that one online too?
Yeah.
Yeah.
Oh, exam 5's online too? What is going on?
It says it's available until the 5th, so I don't know if you give us one day to take it, or we have the week to take it.
So let me look it up. And then I have some notes on tracheostomies to tell you. You guys wanna take a break? And then we'll do the rest of them?
Are we doing the last slide, or was that part of the last slide?
I thought that was the last one.
Okay, I didn't realize the transition button.
Alright, let me check.
Go back to the posturing, isn't one one of them considered worse?
Yes.
Which one is that?
The cerebral?
December.
Available on December 5th until December 7th.
Okay, so we,
Yeah, we have 2 days. That's good. I can focus on it.
You have 60 minutes. When you start the exam, it gives you 60 minutes. And I need to send you the password by approved, vital sign, RSP, structured airway. Alright, so the question is when you can. Okay, so there's no sickle cell questions.
Are we taking a break, Yvonne?
Yes.